distinguishing and managing heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. May I invite Dr. Renita Marina Pinto to the podium.
With MBBS and MD anesthesia, postdoctorate fellowship in cardiac anesthesia, and certification in advanced perioperative transesophageal echocardiography. A passionate regional anesthesia and point-of-care ultrasound enthusiast, faculty for the Aurora Regional Anesthesia Fellowship with deep commitment to medical teaching. I welcome Dr. Renita.
Good morning, all. Thank you for the introduction. At the outset, I bring warm welcome from Aster CMI Hospital, and I'm in debt to Dr. Preeti Jain and the organizing team for giving me this opportunity to be part of this conference. Heart failure is a progressive disease with an annual mortality of about 10%. The main causes of death are the sudden cardiac death occurring in about 50% of the individuals, or organ dysfunction secondary due to low cardiac output state. The prevalence of this is steadily rising owing to better recognition, aging population, and reduced mortality from conditions leading to heart failure due to advances in treatment. And hence, more and more patients with heart failure may present to us for non-cardiac surgery. Now let's begin with this case scenario 1. A 70-year-old patient with type 2 diabetes mellitus, hypertension, obesity, a BMI of 35 with fracture neck of femur was scheduled for bipolar hemiarthroplasty. Preoperatively, his labs were unremarkable. However, echo showed a EF of 55, grade 2 diastolic dysfunction, and concentric LVH. Subarachnoid block with ASA standard monitors was planned. Post-subarachnoid block, the heart rate increased and the BP dropped to about 80/50, which was managed with 500 ml of fluid bolus. 15 minutes later, patient complained of breathlessness with marginal improvement in blood pressure, and saturation dropped to about 90% in room air. What do you think is a probable cause for his desaturation? Now let's revisit this case a little later. Heart failure has many definitions, some being more ambiguous than others. To address this, in 2021, the various cardiology societies developed a universal definition and classification of heart failure. They defined heart failure as a clinical syndrome with current or prior symptoms and/or signs caused by structural and/or functional cardiac abnormality, corroborated by at least one of the following, that is elevated natriuretic peptide levels and objective evidence of cardiogenic pulmonary or systemic congestion. Further, they revised the heart failure classification and proposed new heart failure classification based on ejection fraction as heart failure with reduced ejection fraction for heart failure with EF less than or equal to 40%, heart failure with preserved ejection fraction for heart failure with ejection fraction more than or equal to 50%. They introduced two new terminologies, that is heart failure with mildly reduced ejection fraction for EF between 41 to 49%, and heart failure with improved ejection fraction for heart failure with a baseline ejection fraction of less than or equal to 40% and a 10-point increase from the baseline with a second reading more than 40%. They introduced these two terminologies to distinguish between severely reduced ejection fraction from mild reductions at baseline, and it provides a trajectory of disease. Further, heart failure is a continuum. To emphasize this, the American College of Cardiology and the American Heart Association describes heart failure disease progression with well-recognized stages as stage A, that is at risk for heart failure, stage B, that is pre-heart failure, Stage C, heart failure, and stage D is advanced heart failure. Now, these stages are dynamic and are applicable for both, that is heart failure with reduced ejection fraction as well as heart failure with preserved ejection fraction. For patients with heart failure C and D, it is important to classify them with NYHA classification as well, as worsening of dyspnea is associated with worse prognosis. And for anesthetists, these stages help in risk stratification. Etiology. The etiology of both the heart failures have significant overlap and consist of obesity, hypertension, chronic kidney disease, as well as diabetes. Apart from this, patients with heart failure with reduced ejection fraction are usually younger, males, and it is characterized by cardiomyocyte loss secondary due to myocardial infarction, myocarditis, or volume overloaded valvular heart diseases like mitral regurgitation, aortic regurgitation. On the contrary, heart failure with preserved ejection fraction usually shows a female preponderance, and the patients are usually older, and it is characterized by structural and cellular alterations, including cardiomyocyte hypertrophy, fibrosis, as well as inflammation, all leading to inability of ventricle to relax. Secondarily, heart failure with preserved ejection fraction has a higher prevalence of non-cardiac comorbidities like chronic obstructive airway disease, liver diseases, OSA, cancer, as well as gout. Moving on to pathophysiology. In heart failure with reduced ejection fraction, an initial insult impairs the contractile activity of cardiac myocytes, which decreases the cardiac output, which in turn activates the compensatory mechanisms, leading to increased sympathetic nervous activity as well as renin-angiotensin-aldosterone mechanism, which initially tries to restore the perfusion, but eventually results in increased afterload, wall stress, as well as preload, eventually leading to heart failure. Now, these maladaptive responses occur simultaneously, rather sequentially, in a vicious cycle culminating in heart failure. On the contrary, in heart failure with preserved ejection fraction, the pathophysiology is intricate and not well understood. Chronic hypertension or pressure overloaded valvular heart disease like aortic stenosis result in ventricular remodeling, that is concentric left ventricular hypertrophy, impairing diastolic relaxation. The recent data suggests a pro-inflammatory state induced by non-cardiovascular comorbids like obesity, diabetes, COPD, CKD, all resulting in a systemic microvascular endothelial dysfunction, resulting in left ventricular stiffness. And hence, this non-compliant left ventricle fills at a higher left ventricular end diastolic pressure, leading to elevated left atrial pressures and eventually leading to right heart dysfunction and systemic congestion. Heart failure is a clinical diagnosis. If heart failure is suspected, then an ECG is advised. A normal ECG makes the diagnosis of heart failure unlikely. But if ECG is abnormal, then natriuretic peptides measurement is recommended. Now, these natriuretic peptides are released by cardiomyocytes in response to increased left ventricular wall stress, and they have a very high negative predictive value of about 94 to 99%. However, in heart failure with preserved ejection fraction, these natriuretic peptides may be falsely low due to normalization of wall stress by concentric left ventricular hypertrophy. If enzymes are elevated or if there is high suspicion, echocardiography is suggested, which is a key investigation to assess cardiac function. If abnormal, confirms heart failure, the phenotype and the etiology is determined and treatment is initiated. Pharmacotherapy is a cornerstone of treatment of heart failure with reduced ejection fraction and consists of AC inhibitors or angiotensin receptor neprilysin inhibitors, beta blockers, mineralocorticoid receptor antagonists, and sodium glucose cotransporter type 2 inhibitors, as well as loop diuretics for fluid retention. Now, these should be considered before initiating device therapy alongside non-pharmacological therapies. On the contrary, till recently, there were no obvious guidelines for the treatment of heart failure with preserved ejection fraction. In 2023, the focus update of the 2021 European Society Cardiology Guidelines for the diagnosis and treatment of acute and chronic heart failure recommended diuretics for fluid retention, SGLT2 inhibitors, and treatment of etiology, that is cardiovascular and non-cardiovascular comorbidities, as first line for heart failure with preserved ejection fraction. Now, patients with heart failure are at increased risk of major adverse cardiac events following non-cardiac surgeries. Further, patients with or without prior history of decompensation may decompensate acutely in the perioperative period. To add, a newly diagnosed cardiac failure patient should be medically managed for at least 3 months before an elective surgery. Preoperatively, the functional capacity of the patient should be assessed with objective as well as non-subjective methods, and the stage of heart failure should be determined and risk stratified. Associated comorbidities, especially in heart failure with preserved ejection fraction patient, should be assessed and optimized. A preoperative cardiology consultation is recommended to help in risk stratification and optimization. Appropriate specialist consultation and device integration or reprogramming is required if device is present, and elective surgeries for patients with VADs should be scheduled in specialized centers. Medication review is a critical part of preoperative evaluation. In general, most of the heart failure medications are continued in the preoperative period, except AC inhibitors or ARBs, which should be withheld for 24 hours, that is on the morning of surgery, to avoid hypotension. However, this should be individualized depending on the type of surgery. Withholding antiplatelets, anticoagulants should also be individualized depending on the bleeding risk of surgery, the need for anticoagulation, as well as requirement for bridging. SGLT2 inhibitors should be withheld for a period of 48 to 72 hours prior to the surgery, elective surgery. During this phase, the blood glucose and ketone should be closely monitored, as these patients are prone for euglycemic diabetic ketoacidosis. Now, this is a slide showing stepwise approach for cardiovascular risk assessment and management. Due to time constraint, will not be going through the details through this. Anesthesia management for patients with heart failure basically depends on type of heart failure, degree of heart failure, associated comorbids, and the surgical procedure. And there is no strong evidence suggesting that one anesthetic technique is better than the other. For patients with stage A, stage B heart failure, peri-op continuation of the therapy, avoidance of drugs that worsen the heart failure, and close attention to fluid balance, analgesia, normothermia, sinus rhythm, and optimal treatment of comorbids usually suffices. But patients with stage C, stage D heart failure present significant challenges. Irrespective of the anesthetic technique chosen, the anesthetic goals can be explained in terms of preload, afterload, contractility, rhythm, and PVR, that is pulmonary vascular resistance. In patients with heart failure with reduced ejection fraction, preload reduction is essential, and this can be achieved by pre-op diuresis and meticulous intra-fluid administration. Contractility should be preserved by cautious titration of anesthetic agents and early initiation of inotropes. Afterload to be maintained, as high SVR increases the myocardial work and decreases the cardiac output, whereas too low SVR decreases the perfusion. Rhythm, it's wise to maintain sinus rhythm, especially if there is added diastolic dysfunction. PVR, slight reduction in PVR usually offloads the LV and increases the VQ matching. On the contrary, in patients with heart failure with preserved ejection fraction, avoid aggressive diuresis. Now, these people have thick left ventricle, which depends on the end diastolic volume to maintain tissue perfusion. To add, fluid overload is poorly tolerated. Hence, this is known as the teaspoon physiology. Contractility to be maintained by cautious titration of anesthetic agents. Afterload, the thick myocardium tolerates hypotension poorly and hence should be maintained. Rhythm, The thick myocardium tolerates tachycardia poorly as it is dependent on the diastolic filling time.
Circulatory collapse.
Diastolic filling time as well as the atrial contraction. Hence, rapid cardioversion is indicated in case of atrial fibrillation. PVR, avoid decreases in PVR as blood may flood the pulmonary capillaries. Invasive monitoring, intraarterial catheter, central venous catheter, cardiac output monitoring, and transesophageal echocardiography, if expertise is available, are recommended. However, routine use of PA catheters is not recommended. BIS, by monitoring the depth of anesthesia, can help to titrate anesthetic agents if general anesthesia is warranted. Point of care ultrasound, that is FATE, and lung ultrasound. As you can see the clip of a lung ultrasound showing curly B lines. That's pulmonary edema on the top picture. And this is mitral regurgitation in a apical four-chamber view. Can help to identify early any pre-op decompensation. Peripheral nerve blocks cause least hemodynamic variation and hence should be considered whenever feasible. Revisiting the case scenario 1. The echo features are suggestive of stage B heart failure with preserved ejection fraction, and hence most probable cause is acute pulmonary edema precipitated with fluid bolus in a patient with heart failure with preserved ejection fraction, and the clip shows pulmonary edema, that is a lung ultrasound. Postoperatively, stage A, stage B patients, if stable, can be shifted to the ward. However, stage C and stage D patients should be preferably managed in a high dependency unit or ICU for a period of 48 hours, where they should be monitored for major adverse cardiovascular events as well as euglycemic diabetic ketoacidosis. Serial cardiac markers should be measured. Wrapping up, normal EF is not synonymous with normal cardiac function. In heart failure with reduced ejection fraction, pump is weak, so support the contractility and maintain or diurese preoperatively. In heart failure with preserved ejection fraction, pump is stiff. Avoid tachycardia and fluid overload and maintain sinus rhythm. Thank you.